Laurence Aubigez presented at ESMO the LightSpark-005 data that got Belzutifan just recently approved here in the United States. And then Dr. Thomas Powell's presented the quality of life data, and so kind of a similar type situation where we're saying, well, we think we see a certain patient population who's having a durable effect, and that the quality of life in these in patients with RCC who have been through prior treatments, is perhaps enhanced. So now I'll throw it to you and just ask, thinking of that data and then seeing this Tivozanib data, how do you relate those, or how do you think about that in your clinical practice?
Yeah, I mean, I think we have an embarrassment of riches, certainly. So we have choices, but what anyone who treats kidney cancer today, we expose our patients to some therapies that are very powerful therapies, but they also bring to a lot of baggage of really side effects, and you really see that in the reports of the trials where 2/3 or more of patients are requiring dose reductions to stay on therapy. But those therapies have great efficacy. I don't think that that some of the emerging therapies like Tivozanib and even Belzutifan necessarily have some of the tumor shrinkage ability of maybe Lenalidomide and Cabo. So I think it'd be interesting if we did a head-to-head trial to see what that looked like. But the goal for some of these patients that are getting those drugs in second line and third line may be different again as you move into later line past that. So you're still the other thing is combination approaches. So I think both Tivozanib, which has a combination strategy, Tivo-Nivo is a study, the phase 3 trial that we're waiting for results with, and so that it has a combination strategy similar to a really similar drug, which would be Inlyta. It's similar in some regards that it tends to be more focused at the picomolar concentrations at VEGF with less off-target effects, but the PK profile of the drugs are completely different, where Inlyta, as you know, is more on a twice-a-day dosing, and there's some thoughts of maybe that helps with side effect management. And then another strategy of looking at things is, hey, there's a PK advantage of keeping the receptors occupied, and Tivozanib offers that. And so it gives you kind of a completely opposite view where an equally tolerable drug, but a different PK profile of that. So both of those, and then Belzutifan, it may truly not be, its claim to fame truly may not be as a single agent. So it may be something that is combinable into a Lem-Pembro or one of those type of regimens, and studies are ongoing to determine whether or not there's a benefit to triplet therapy. And so from that perspective, if we do think that like a Belzutifan type drug, or maybe even some third generation therapies that are entering phase 1 trials, if they come out and end up being in a combination strategy, then Tivozanib's role is still there as one of these great drugs to have in a refractory patient population. And I tell you that when I get ready to use Tivozanib as a third or fourth line treatment option for my patient, they're ready for it. They're ready to have a relief of side effects and to show a maintenance of benefit, and showing that some patients will get tumor shrinkage, but then other patients will have stable disease. 2/3 or more patients are going to have stable disease for some length of time on it with a good quality of life. I think it's really good, refreshing for our patients. And that's why when I'm giving lectures or when I'm trying to educate my community colleagues, I really want them to think of this agent as an agent that should be considered one of the agents they choose in the first several lines of therapy. I mean, we've got 10 or 11 to choose from, but really, there's no reason not to be wanting to use this. In fact, I consider Tivozanib as a second generation therapy, even though I've had experience of it way back in 2010. We've had this drug, but I think of it as a second generation therapy. And really, all of the second generation therapies have really beaten the first generation therapy. So we should not be going for a Nexavar drug or Sorafenib drug, going for a Sunitinib, going for a Pazopanib drug in the third and fourth line setting. We've got this drug, and this drug has shown benefit with less side effects. And unfortunately, and I'm sure you see this in your clinic, I still see patients referred in that for some reason have gotten exposed to one of the first generation drugs. And I don't necessarily think that's ideal, especially when you have data sets and lack of data in those situations. So it's a great opportunity. It's a great time for kidney cancer patients, right? We've got all these new therapy options, and it's great that we still have some that have activity with such great tolerance.
Yeah, I agree. And that was a great review, I think, of kind of what we're looking forward to in the future to see, many of these trials, as you said, maybe some combinations, maybe these active drugs in the refractory setting will end up moving up, but still having a multitude of treatment options, which is wonderful. I wonder, for community physicians or others who are trying to make a decision, maybe you're a third line patient, are there certain clinical features that make you choose one therapy over another, or certain clinical trial
Yeah.
features that you've seen that make you choose one over the other, given that we don't have a biomarker for, the refractory or for any RCC treatment?
Yeah. So for me, it makes, it's pretty easy for me because of my sequence off of a trial is going to involve len pembro as a first line agent. And so the Lenvima product, which, if I didn't use that, would leave, would have Len-Ev as an option. So I don't have to worry about that. I know the most commonly used based on data is use data is Cabo. So that takes that, people using Cabo-Nivo as a frontline option or len pembro. So really Tivozanib is placed greatly in a third line setting because you can get whichever the Cabo or Len product you don't use as a second line agent, and then you're talking really about Tivozanib, and then your Belzutifan, which is on the market, and then the question is which one do you sequence in which order? And I don't have a magic for that. I know that you have the greatest data, obviously, with Tivozanib. I really want patients exposed to both of those agents. So it's really hard for me. I think the selling point right now for a community oncologist is, you've got two of these drugs. You want to use them both, which one you use next or not, but you've got two lines there and you want to get exposure of both of those agents to your patient. So I don't know if you have any keys there. I don't know. It'd be kind of a judgment call. Obviously, things like insurance coverage and availability of therapy and cost of care and things like that factor in. But I ultimately want exposure to both.
Yeah, no, I think you're right. I think I hope that all my patients get to see all of these
Yeah.
effective therapies. And, I think sometimes the time to response maybe on that Belzutifan curve pushes me kind of one way or another.
Yeah. Yeah.
But otherwise, I'm hoping that I'll be able to just sequence one past the other. So this has been really great and very enlightening. I think we've covered the whole gamut from refractory RCC, and any other things that you think we should highlight about this?
No, I mean, I think both drugs are great. For Tivozanib, I'm just thinking of a numerous early studies right now where Tivozanib is a combination partner. I think the future, is now moving into the third generation of therapies, which are in phase 1 and early drug studies and combination strategies, both with Belzutifan type drug and with Tivozanib and some of the other second generation drugs. And I think there's a lot of great hope there. And that's where I'm aimed at now is, we have what we have now. There's a population and the majority of people are not cured. They need other therapies. So looking at some of these novel therapies with novel mechanisms of action that are overcoming some of the resistance to checkpoint inhibitors and can help synergize with some of our oral TKIs is where the future is. So I'm really future focused and phase 1, 2 focused right now and pushing the field.